Hi, my dear lovely friends. A wonderful good evening to all of you. Today, we'll be interacting and we'll be trying to see the important topics from where, in the current pattern of examination, the NB people are asking questions. First of all, I would like to tell you, beta, that what is the total plan for today's session. Today, first, we'll be discussing about the 25 most important topics from where we do expect that some of the questions would be there in the exam. Also, I would like to tell you, beta, these may not be the exact questions or there might be different framing of the question, but definitely, yes, with the experience what we have gained over a period of time, this is my personal opinion that these might be the relevant important topics from where the questions can be asked. Number two, once we are done with how we have to solve these clinical questions, what type of questions, how to solve those different questions, and what we need to stay focused on while answering them in the exam. We'll be doing that in the discussion of these 25 important clinical questions. Apart from this, in the end of the session, I would also like to give the missed experience about what is the overall question paper, what is the weightage, what are the do's and don'ts, what are the important topics in different subjects apart from surgery as well. And I would like to reiterate the study plan, what we have carved out as an initiative from our side. Also, this entire session, which would take us approximately 2 hours or maybe a little more than 2 hours approximately, this session should not be taken as that this is the only thing what is going to come in the exam. This is just an effort, just an initiative from our side that probably this might help you in the 4th of June exam. Right, beta? So, before I just take you to those 25 questions, I would just like to tell you that in surgery, how many questions are generally going to be there in the exam. The examiner says that there should be 32 questions from surgery. Out of these 32 questions, first of all, let me tell you that approximately 20 to 25% of questions should be image-based questions. 20% should be image-based questions. Then 20% would be the golden facts. Now, golden facts are something, beta, which we keep on learning, and we keep on chanting them like anything so that we do not commit any silly mistakes in those type of questions, which were earlier referred to as the single liner questions. Now, the big game changer for you as far as surgery is concerned, 60%, beta, please make a note, 60% of the questions are going to be the conceptual questions. That means the knowledge what you have gained while you have attended the different lectures of surgery from whatever source, those concepts are going to be the key for solving these game changer 60% of questions. And then 20% of the questions, I believe, they would be unheard questions in surgery. Unheard questions, right? So, what we want to achieve on 4th of June is we want to go for the kill for 4th of June and we have to achieve success come what may. We have to do it and we are going to do it. So to do it, what we need to do is we need to focus on that we should not miss out here. And my dear friends, beta, in the golden facts, avoid silly mistakes. Avoid silly mistakes. This is going to be the key, beta, because every question, whether it is a golden fact or a single liner question, or it is a conceptual based question, or it is an unheard question, every question carry the same weightage There is no negative marking, so you get 1 out of 1. So please make sure that you are not committing silly mistakes here. And the conceptual questions, yes, the knowledge what you have gained, the concepts what you have learned in the classes, they are going to decide how we are going to prove ourselves in these 60% of questions. So give due respect to these questions and solve them according to your clinical acumen. While the questions which you are unheard of, now here I would like to tell you beta that one small attempt what we can do here is look at the options. Look at the options. Before saying no to these type of questions, say I will try, and then try to give your best for these type of questions, right? Okay, fine. Now, how to solve these different type of questions beta? For different type of questions, like for image based questions, the dictum is look at the image first, then look at the options, then the last line of the question, and then if needed you go to the stem of the question. This is what is the best method to solve the image based questions. Number 2, the lengthy questions. Now, lengthy questions, read the last line of the question first, then look at the options. Why it is important beta to look at the options? Because when you're reading those lengthy questions, your time is getting wasted. So this time management is going to be a key factor in the exam. So instead of wasting your time in focusing on different type of clinical possibilities while you're reading the stem of the question, if you already have read the options first, your eyes will be focusing only on those 4 given pathologies rather than focusing on 10 different type of pathologies. Now you have to read the stem of the question after this, right? So this is what we have to take care of. And needless to specify once again beta that the small questions, or you can say the single liner questions, please be careful about the terms like true, false, except, like this, right? So that avoid silly mistakes here. Okay, so this is what we have to focus on in these areas. Now the third thing beta which I would like to mention here, that what are the different topics from where the questions are going to be there. I don't know beta that how many questions are going to be from different topics, but as far as surgery is concerned, if I divide the surgery into general surgery, now general surgery includes the trauma section. If I say there are 32 questions from surgery, then roughly, approximately, you will be getting around 6 questions from trauma. Then vascular surgery, you will be getting approximately 2 to 3 questions here. And the endocrine surgery, which comprises of the thyroid and the breast, as far as the surgical aspect is concerned, you will be again getting 2 to 3 questions from this endocrine surgery. Then apart from this, in the systemic surgery, pediatric surgery, we'll be getting approximately 6 questions from pediatric surgery. Adult surgery, now this is going to be really a bulky area from where we'll be getting a lot of questions in the exam. In adult surgery, we expect approximately, you can say, 14 questions. 14 questions from this adult surgery should be there. And Then comes the oncosurgery. Now, oncosurgery, we might get maybe 3 questions or something like that. 3, or sometimes they may even go up to 6. So the number of questions obviously would be variable. This is not the exact thing, but this is just based on the experiences what we have had. So if we just take a look, approximately 12, 14, 16, 30, 33, 36, around 35 questions are mentioned here. So out of these 35, this should be the final distribution. However, it may vary depending on the examiner, right, beta? So we are going to talk about these different topics according to this weightage, and we'll be going in this particular sequence only. First, we'll be talking about the trauma questions. Now, in this trauma section, beta, I would just like to specify that in trauma, the examiner would be focusing on the primary assessment. The examiner will believe that they are giving you the license, beta. Okay, so 4th of June, you are going to get the license. Now, the examiner is thinking that you are sitting in the hospital, and if you are sitting in the emergency, your first aim should be to save the life of this patient. And to save the life of this patient, we know what is most important, beta. The most important thing, beta, just to remember in the concepts, look at me here, just to remember, we want that oxygen is something which is most important for all of us. हम लोग कैसे जिंदा रहते हैं बेटा? ऑक्सीजन से रहते ना? So just remember that you are the doctor and you have to make sure that oxygen is reaching to every cell of the body, every cell of the body. And right now, all of you are sitting here, you see the oxygen is going from this area, and then it is going into the lungs, and from there it is going into the circulation, and from the circulation it is distributed into different tissues, different cells of the body. So as a doctor, what you have to ensure is that this passage, this track, ये जो रास्ता है ऑक्सीजन का, ये आपको ensure करना है कि पेटेंट रहे. उसके लिए either you might have to go for this airway securement, the proper lung expansion, the circulatory volume. This is what we say A, B, and C. And then very important is we need to assess the Glasgow Coma scale in these patients, right? And once sorry, the life of the patient is saved, then we have to look at the different traumas, like starting from top to bottom, the head injury, the face injury, the neck injury, the chest, the abdomen, and the limb trauma. Limb trauma is something which is dealt nicely in orthopedics, right? So out of these trauma areas, the head trauma, where the examiner focuses on extradural, subdural, these are going to be the hot topics out there. The chest trauma, mark my words, beta, you are going to get one X-ray. Mark my words, you are going to get at least one X-ray related to either pneumothorax, tension pneumothorax, hemothorax, or maybe a flail chest story. So the chest X-rays are going to be important in thoracic trauma in the exam. In the abdominal trauma, there is one table: how to manage a blunt abdominal trauma, how to manage a penetrating abdominal trauma, and how to manage a retroperitoneal trauma. So that table is going to be crucial. You will be getting at least one question from this abdominal trauma management, right? Okay, so these are hot areas in the trauma. And then you might rarely get a question from burns. Looking at the current pattern of examination, the weightage what the examiner is giving to burns is slowly decreasing. But yes, we can have this one question. So this is going to be the trauma distribution for you. Now let us take a look at the questions here, starting with this. Yeah. Mr. X, 30-year-old, emergency. Now look, beta, this looks to be a lengthy question, right? So instead of reading from the start, let us try to read it from the bottom, okay? So here the last line of the question says his Glasgow coma score is. So we have to just focus on the GCS. Now quickly look at the options. Here in the options, he is focusing on eye, verbal, and motor. All the options are almost there, eye, verbal, and motor. So now I have to just focus, I have to just extract the keywords for I, verbal and motor. This is how you're going to solve the question with us. Okay, 30-year-old, emergency, road traffic accident, irritable and using abusive language. Abusive language. Now this is my verbal, right? Now his peripheral pulses are not palpable, but carotid is palpable. He opens his eyes on voice command. Eyes on voice command. So this is another keyword for me, beta. And shows withdrawal, normal flexion movement in the lower limbs. Now this is going to be the key for me. Let me just quickly go through what is this Glasgow Coma score or Glasgow Coma scale. So herein, if I just try to see that eye response, if the patient is able to open the eyes spontaneously, we give him an eye score of 4. If we have to give a voice command, 3. If we have to give pressure or pain, then it is 2. And if there is no response, then it is 1. Right, beta? So this is how eye score is calculated. Regarding verbal scoring, if the patient is fully conscious and oriented, then the verbal score is 5. If the patient is confused, then the verbal score is 4. If he is using inappropriate words, now beta, this is going to be the key for us in this question. Inappropriate words, abusive language, 3. If he's not able to speak out any words, he's just making some sound like only sounds, no words, incomprehensible sounds, then it is 2. And if no sound is coming out, then it is 1. So this is how we are going to calculate the verbal response. Regarding motor response, beta, quickly let's go through it. If he is able to obey all your commands, then the motor score is 6. If he is just localizing your commands, then the motor score is 5. If he withdraws or shows normal flexion, this is 4. And if there is abnormal flexion, then this is 3. Extension, my dear doctors, is 2. And no movement at all is 1. So this is how the entire Glasgow Coma scale is measured. In this Glasgow Coma scale, beta, in the given question, we know what they are asking is, they're just trying to ask us that he's opening his eyes on voice command, he's using abusive language, and he is showing withdrawal, normal flexion movement. So I'm very, very clear what is going to be the Glasgow Coma score in this patient. Right, very good. Great. In this, what else can be asked in the exam, beta? They may ask you what is mild, moderate and severe. So you should know, beta, mild, moderate and severe. Mild is something which is 13 to 15. 9 to 12 is moderate. And severe is 8 or less than 8. So just to make you remember it, because now the exam is very, very close. 9 se 12. Chalti kya 9 se 12. 9 se 12 is moderate. 9 to 12 is moderate. Just remember that. And then the mild and severe, you can easily crack it. Also, my dear friends, motor score is something which is the best for prognosis. Motor score is best for prognosis. And if you are not able to assess any score, for example, if you have put the endotracheal tube in this patient, then you will not be able to assess the verbal score. So there we use the term NT. NT means non-testable, beta, non-testable, right? So these are going to be the keywords related to Glasgow Coma score. And I hope you're not going to miss out on 4th of June if there is any question from this Glasgow Coma score. Right, beta. So now here, if we take a look, I3, verbal 3 and motor 4. Is that in the option? Yes, it is there in the option. So if I take a look, my correct answer should be E3, V3, M4. Now let me quickly take a look. Yes, beta, majority of you have answered correctly. Wonderful. Great. Rizwana, Sadhna, Umang, Satish, VK Vlogs, Bhavin, Bit 2, Shrishti, wonderful beta. Let's have a big round of applause for all of you. So you are able to crack it, and those who are not able to crack it, do not get disheartened beta. Just try to identify where did we lag. Where did we lag? Now where did we lag means whether we did not read the question carefully or we did not remember this Glasgow Coma scale. And beta G, you are going to be the best judge to understand this problem. And if you're not able to remember this Glasgow Coma scale, just quickly today, just take out 3 minutes and quickly revise this Glasgow Coma scale so that you don't miss out on 4th of June. Right, beta? Just stay positive at all times. Yes, we still have got a number of days to go, and still we have got a lot of things to revise. We'll do it definitely. Now, beta, let's go to the second question in the series. This looks to be a small question, but this is an image-based question. So let me just focus on the image here. For me, this looks to be a CT scan image. And my dear doctors, if I carefully take a look, I can find something here. Some white hyperdense shadow is seen here. Can you see, beta? There is a white hyperdense shadow. And we know that all fresh bleeds on CT scan appear white. This is a CT scan of the head. You can also see there is some midline shift also is evident here. Now this is a bleed inside, right? Now what is this? For me, what I know is that when I was reading, I saw different type of CT scan images. Like if I look at this, this is also a CT scan of the head here. This is a bleed area. Can you see this bleed area, beta? All fresh bleeds appear white hyperdense on CT scan. And this looks to be convex hyperdense. So convex bleed, I know this is an extradural hematoma. Also, my dear friends, if I just take a look at this particular picture, this also looks to be bleed. This also is convex, and this is in both the frontal region. So this again is a bilateral extradural hematoma. Convex is extradural, beta. Convex is extradural. Convex CX, extra EX, दोनों में X आ रहा है बेटा, तो convex is extradural. But here, if I take a look at this particular picture, can you see this, beta? This is not convex. This border is concave, and concave hyperdense is something which I see in subdural hematoma. Right? So this is the basic information what I have. Right? Now let me just take a look at the question what he's trying to ask. Elderly person, let me just have a look at the options. For me, it looks to be a subdural hematoma. Is it a scalp hematoma? I'm not seeing any hematoma in the scalp area. Basal skull fracture. I'm not able to find out any fracture in the base of the skull. Extradural should have been convex. Subdural should be concave. Yes. So my answer for this question should be subdural. But before I mark, beta, most likely diagnosis. This is what he has asked. That means I'm thinking correctly. It is a subdural hematoma. Elderly person, after waking up in the morning, suddenly fell on the ground after standing and suffered injury as shown in the CT scan head. So most likely diagnosis, yes, beta, this is a subdural hematoma. And here I would just like to remind you, beta, that this image, what you're seeing here, this was the first image-based question in the history of FMGE exam when it started in the year 2015. And this extradural hematoma image has been asked a number of times in your exams. Also, beta, I would just like to ensure one thing here, that in your exams, they are focusing on the extradural and the subdural hematomas, not only on the images. Just a quick revision of the most important points of extradural or epidural hematoma, beta. Most commonly, this is seen in the temporoparietal region. कौन सी जगह मिलता है बेटा? ये temporoparietal region. Temporoparietal region, right? Apart from this, yes. Apart from this, this is due to injury to which artery, beta? Middle meningeal artery. Middle meningeal artery. Right. Apart from this, lucid interval. Now, beta, this is asked number of times again. Lucid interval. So there can be a question on lucid interval as well. However, in the last December exam, they asked a single liner question, lucid interval is seen in, and the answer was extradural hematoma. But generally the questions what they are framing, they are giving a clinical situation. Lucid interval, we know, is a transient period of consciousness after trauma wherein the patient remains fully conscious and can carry out the normal routine activities. Now they might give you example of a cricket match going on, suddenly a bouncer, and that bouncer caused injury to the head. The patient fell on the ground, the batsman fell on the ground, and soon he regained his consciousness, scored a good amount of runs, maybe a century or something, and then collapsed after the match. So this period was lucid interval because he was absolutely fine. They may give you an example of a rugby player. They may give you the example of a discotheque where the person was doing some mischief inside the disco, and suddenly he was hit by the boxer on the head. He became unconscious, but he regained his consciousness. Then he went to some other disco, enjoyed the whole night, but collapsed in the morning. So these can be the different clinical framing of the questions. But what they want to know is whether you know the concept of lucid interval or not. And I'm pretty sure, beta, that all of you would be knowing about this. Pranav, you have asked a question, how is abnormal flexion and extension mentioned in the question? Abnormal flexion, beta, this something is the normal flexion, but suppose he's making an abnormal flexion movement like this is what is abnormal flexion. And if you ask the patient to suppose raise his limb, instead of raising the limb like this, he's showing some extension type of movement, then this is how we can assess. Right. So this EDH, these are the three hot areas in EDH. And subdural hematoma, this is due to injury to bridging cortical veins. Okay, so please do remember, do not miss out on these important points. This is again a hot topic for your exam. Moving further, beta, Mr. X 26, again this looks to be a lengthy question. Let me try to manage my time. Time management is going to be the key here. So let me read the last line of the question first quickly. What should be the immediate step to resolve the respiratory distress? Oh, so there might be some story cooked related to respiratory distress. Okay, let us see. He's asking very clearly, beta, to avoid silly mistake, you have to focus here, immediate step, okay, to resolve the respiratory distress. Fine. Let me look at the options quickly. Endotracheal intubation, okay, laryngeal mask airway, needle thoracocentesis, and tube thoracocentesis. Okay, quickly, endotracheal intubation should be the answer. If there is a traffic jam somewhere here, and suppose the patient is not able to breathe, right? Suppose he is not able to access this oxygen through his nose and the mouth. So let us just quickly put the endotracheal tube. Laryngeal mask airway, again for the same story. Needle thoracocentesis is something what we do in cases of tension pneumothorax. Tension pneumothorax, when there is high pressure building up inside the pleural cavity due to massive air going inside the pleural cavity. So for that, the patient is going to die within seconds or minutes. Just to prevent that, we just put a needle quickly. And tube thoracocentesis, tube is put in the intercostal space. Definitely when there is any collection like pneumothorax or hemothorax, but since tube is going to take some time, so this is not something what we do in a distress type of situation. This we do definitely to solve the dyspnea problem, but not the respiratory distress type of problem. So this is the understanding what I have right now. Let me quickly read through the question. Mr. X, 26-year-old, driving a motorcycle, high speed, accident, emergency, respiratory distress, severe breathing difficulty. Okay, severe breathing difficulty. Yes, he's not having any signs of debris or mud in the mouth. Engorged and dilated neck veins. Engorged and dilated neck veins. Okay. On chest X-ray, there is massive air collection in the right pleural cavity with trachea shifted to the left side. Oh, so my dear friends, he has mentioned what is tension pneumothorax in the question. Let us take a look at this story here, beta. What happens if there is massive injury, suppose on the right side here? What is going to happen? Suddenly, yeah, so here you can see there is massive collection of air which is pushing the lung. So there is ipsilateral lung collapse. बेटा एक साइड का लंग कोलैप्स हो गया तो ये लंग हवा की वजह से एक्सपेंड नहीं हो पा रहा है ना. This lung is not able to expand because of lot of air here. Also, there is so much of air collection that it is putting the pressure on the trachea as well. So there is a midline shift. And this might be putting pressure on the opposite lung also. That means the opposite lung is also not able to expand nicely. That is why the patient is having this respiratory distress beta. Now, since the patient's lungs are not able to expand, the oxygen is not going into his blood beta. So oxygen is not going into the cells, oxygen is not going into the brain. The patient is going to die quickly. If you have to save the life, whatever best is available in the emergency, in the casualty, you have to just pick up. Putting a tube is going to take a time. If you can just put a needle here and drain out the air so that the midline shift is not there, the lung can expand a bit, you might save some 10, 15, 20 minutes for this patient, wherein then you can put a tube. So immediately you should put a needle, and this is something what we know about, that where the needle has to be put. In an adult patient, needle thoracocentesis, intention pneumothorax, we put the needle in the 4th or 5th intercostal space just anterior to the mid-axillary line, while in children, we put the needle in the 2nd intercostal space in the mid-clavicular line. Okay, so this is for needle thoracocentesis. Generally, a 14-gauge needle is used. So I hope, beta, this thing is absolutely clear for us that we want the lungs to expand, and for this we are going to do a needle thoracocentesis. Now, can we quickly take a look? Yes. Oh, okay. Okay, so majority of you have answered it correctly, I guess. Very good, Deepak, Jacob, Krishna, Saurabh, Umar, Ajit, you marked it right. Dilated neck vein, yes. Yeah, tube. Afsal, I would just like to mention a small thing here, beta, that we will be putting a tube as well, but not immediately. We would be putting a tube later on, right? Okay. Yeah. Dr. Gamer, why not D beta? Because putting a tube, the patient is not having much time. For putting a tube, we need to make an incision. We need to create a space in the pleural cavity, and then we have to put the tube. This is going to take some time, maybe 4 minutes, 5 minutes time, but the patient might die within a minute. So we don't have that much of time. We're just putting a needle quickly so that whatever huge pressure of air is there inside, we are just removing that air pressure quickly so that the lungs can get some space, some oxygen can go inside. Let us buy some minutes, and then we'll put the tube. Yeah. If patient is stable, Shubham, then yes, we are definitely going to put a tube. If no tension pneumothorax type of story is there, we are going to put a tube, right? Dilated neck veins, yes, we know that whenever there is a compression, and if suppose the major veins are compressed here, suppose the superior vena cava is compressed by that air pressure, now what will happen? The blood flow, the neck facial veins, they will not be able to drain the blood if the superior vena cava is compressed. So all the blood will get pooled in the neck facial veins, and that is why they looks to be engorged and dilated. Even in cardiac tamponade, when there is a huge amount of collection around the heart in the pericardial cavity, this also causes compression of the vena cavas, so there is engorged and dilated neck veins in cardiac tamponade also. But my dear doctors, how do we differentiate these two? In cardiac tamponade, the heart sounds will be muffled, breath sounds will be normal. But in tension pneumothorax, the breath sounds will be diminished, heart sounds will not be that muffled. In both, we will be getting engorged, dilated neck veins, right? In pediatric age group, yes, beta, we can use 18-gauge needle in pediatric age group. Very good, beta, very good, Gamma Knife, very good, Onkar. Pneumothorax and tension pneumothorax, Rahul, beta, it is easy. The patient will not be having any distress type of situation in pneumothorax. Just see here, beta. In pneumothorax, there will be collection of air only on this side. It is not going to push the midline structures on the opposite side. The opposite lung is not going to face the pressure. The opposite lung will not be collapsing. All the story will be only on one side, right? If one lung is working nicely, the patient would be able to breathe. The patient will not be in respiratory distress type of situation if it is a simple pneumothorax type of story. But in tension pneumothorax, yes, the patient would be in distress, right? No, Rajendra, we don't need any radiological procedure. Patient is not giving us that much of time that we can do any radiological procedure, okay, before putting a needle. But yes, in tube thoracocentesis, we have got sufficient time. We can get the chest X-ray done if needed. Right, beta. So, Mathan for hemothorax immediate management is tube or needle. Tube, beta. Mathan for hemothorax, it is tube. For pneumothorax, it is tube. For tension pneumothorax only, it is needle. Yeah. Fine. Now, let us move to another question here. A 22-year-old male was, again, this looks to be a little lengthy question, so let me try to save some time here. Let me read the last line of the question first. Which of the following should be avoided in the initial management? बेटा जब इस तरह के क्वेश्चन पढ़ रहे हो ना, ध्यान से सुनो. ये दो जो वर्ड्स लिखे ना बेटा, अवॉइडेड और इनिशियल, इस पे ध्यान देना. Avoided and initial, avoided in the initial management. Okay, that means he is indirectly asking all of the following are recommended except. ठीक है बेटा? Okay, so once you have broken this, let us look at the options. C, CT of the abdomen, focused assessment by sonography, that is fast, blood transfusion and tranexamic acid injection. Okay, so let us quickly take a look at the question. He is asking which should be avoided in the initial management. Okay, so this is a 22-year-old male hit by a car crossing the road, suffered from blunt abdominal trauma, pulse rate 120, blood pressure 90/60. Okay, that means if I calculate the shock index quickly, the shock index in this patient, which is the ratio of pulse to systolic blood pressure, this is 120/90, so this shock index is more than 1. The patient is hemodynamically unstable. That means we have to be very aggressive in this patient, otherwise we lose this patient. He was having tachypnea but no obvious clinical evidence of chest trauma. No chest trauma. So there is no chest trauma. Okay. He was started with intravenous normal saline with 2 wide bore IV cannulas. Okay, so IV fluids have been started. Now he's asking, patient is hemodynamically unstable, what should not be done? Okay, fine. So if we just quickly take a look that what is the algorithm for the management of blunt abdominal trauma, blunt trauma of the abdomen beta, if the patient is hemodynamically stable versus patient hemodynamically unstable. That means if the shock index is suppose less than 1 versus shock index more than 1. So how we are going to approach for a stable patient? We admit the patient for observation. Then first investigation, what we are doing here is fast, that is focused assessment by sonography in trauma. Since the patient is hemodynamically stable, patient is not going to die, we have got sufficient time and we can do a CECT of the abdomen in a stable patient. So best investigation for a hemodynamically stable patient after blunt abdominal trauma would be CECT. Depending on the results of CECT, we decide whether the patient require any surgical exploration or not. Majority of the times the treatment is non-operative. For an unstable patient beta, like the given question, if the shock index is more than 1, pulse rate is high, systolic blood pressure is low, We know that we might lose this patient quickly. There might be injury. What is the commonest organ injured in blunt abdominal trauma? Beta, quickly, can I have that from you? Very good. You have already given that answer, Sai Teja. So it is spleen. Manoj, nowadays DPL is becoming obsolete. We are doing fast. Fine. So blunt abdominal trauma, it is spleen. Second is liver. While penetrating abdominal trauma, most common it is liver. Second most common is small intestine. Bomb blast explosion, the sequence is eardrum, trachea, lungs, and the intestines. Right. For an unstable patient, let us just imagine that if suppose a car tire has run over the abdomen, spleen is injured, liver is injured. Now what is happening? They are bleeding like anything. So if there is bleeding, oxygen is going out. So oxygen is not going to different cells. Oxygen is not going to the brain. The patient can die. So what we are trying to do is we are trying to pump in IV fluids just to restore the intravascular volume in this patient. And once we are pumping in IV fluids, we pump in IV crystalloids, normal saline usually. If that is not there, then we can go for other options like ringer lactate, Hartmann solution type of options. We are just trying to pump in IV fluids so that whatever oxygen patient is having in his circulation, at least that oxygen can go to the brain. And there is a stepwise approach. First, IV fluids, more than 30% of blood loss, quickly give blood transfusion, give a hemostatic agent like tranexamic acid, first dose within 10 minutes to 3 hours, second dose to be repeated within 8 hours. Okay. If the patient is not getting stabilized, you are trying to pump in IV fluid. At this point of time only you can do a fast. Quickly you assess the pericardial cavity, the liver and right kidney injuries, the spleen and left kidney injuries, and the pelvis for any free fluid collection. If the patient is not getting stabilized, you do not have any time to get the CECT done in this patient. Patient is going to die if you send this patient in the CT room. So the best thing is, if IV fluids, blood transfusion, hemostats, they are not able to control this bleed, immediately shift this patient in the operation theater, do a laparotomy, apply direct pressure at the bleeding site. Suppose there is bleed from the spleen, apply direct pressure on the spleen so that the bleeding stops. And once the bleeding stops, then whatever fluid you are pumping in the circulation, that fluid will remain inside the circulation. The oxygen levels inside the patient will increase. Okay, so that is what we have to approach for an unstable patient. So most important is basic resuscitation. So we are doing a resuscitation here. While we are doing a resuscitation, we can get the fast done. If the patient is not getting stabilized, then we are doing a urgent exploratory laparotomy by a midline incision, where we use a Pringle's maneuver as well to control the liver bleeds. So beta, looking at this, what we are not doing in an unstable patient, we are not doing a CECT. In the basic resuscitation, we are pumping in IV fluids. We may pump in blood. We may pump in hemostatic agents like tranexamic acid. Okay, so the correct answer for this is CECT of the abdomen, right? So that should be the correct answer for this. Yeah, so it is CECT of the abdomen. Fine. Now moving to another question, beta. This is an image-based question, and in this image, what I am able to see, this is the image which you have seen a number of times in the various social media platforms. We are seeing the color changes in the tip of the fingers, my dear friends. This is white, blue, and then you can note the hyperemia which is coming up. This characteristic sequence of color changes, white, blue, red, is Raynaud's phenomena. Raynaud's disease is commonly seen in young females, where probably there is hypersensitivity of the arterioles which undergo spasm on cold exposure beta. जैसे ही ये यंग फीमेल अपना हाथ ठंडे पानी में डालती हैं, ये उंगलियां एकदम से ये कलर चेंजेस शो करती है, right? Because of spasm of the arterioles, this tip of the fingers become white, Because of stagnation of blood here, they become blue. And when the lady warms her hands, then again the circulation comes up and this becomes red. Now there are two types of Raynaud's beta, primary and secondary. Primary, which is not associated with any other disease. Secondary, which is associated with other diseases, maybe SLE, rheumatoid arthritis, cervical rib, thoracic outlet syndrome, like scleroderma, right? So that is secondary Raynaud's. And what should be the treatment for this Raynaud's beta? Since the pulses are normal in this case, and this is just a hypersensitivity of arterioles, we just advise these patients for lifestyle modification, okay? Just avoid cold exposure, wear warm clothings, and if required, we can give some calcium channel blockers and nitrates, which can keep the arterioles dilated. And very rarely we can go for cervical sympathectomy. So let us just take a look at the question beta quickly. This is a small question. I have seen the image. Now I'm looking at the options here. Secondary Raynaud's syndrome, primary Raynaud's syndrome, acrocyanosis, and gangrene. What I know is this is a Raynaud's, clear cut. 20-year-old female, dysphagia for last few months. Now beta, this is going to be the differentiating feature between primary and secondary. Dysphagia is something which is a feature of scleroderma. Scleroderma beta, there is thickening of tissues in different areas of the body. So just imagine if the esophagus wall gets thickened, right? The patient will have difficulty in swallowing. So dysphagia and scleroderma associated with this Raynaud's. Jaldi se batao beta, will this be primary or secondary? Yes. Will it be primary or secondary? बेटा देखो बहुत सारे बच्चों ने B बोला हुआ है, right? B is what? Primary. Doctor has written A. I repeat beta, primary is something which is not associated with any other disease, while secondary Raynaud's is when Raynaud's is associated with any other disease. Right beta, now perfect. Thank you beta, thank you so very much. Now I can see that all of you have marked this answer A. ठीक है बेटा, तो this can be a silly mistake in the exam अगर हमने इस line को ढंग से नहीं पढ़ा बेटा. Dysphagia for last few months. If you have not read this line properly ना बेटा, तो ये गलती हो सकती है. So please be careful. So the correct answer for this would be secondary Raynaud's. Secondary Raynaud's, right? Good. Let's have a big round of applause for all of you beta. Now you have marked it absolutely correct. Great. Fine. Now let's take a look at another question beta. Patient presenting with pain in the calf and the leg on the right side. Looks to be a little long question. Let me focus on time management here once again. Pulses, what is the most likely site of obstruction? Okay, so he's asking some site of obstruction. Let me look at the option. Aortoiliac arterial on the right side, iliofemoral arterial on the right side, proximal femoral arterial on the right side, distal femoral arterial on the right side. So one thing which I can make out, everything is on the right side. So nothing to be done. Everything in the given options beta, all are arterial. Okay, so now what I have to differentiate is whether it is at the level of aorta iliac, or it is iliofemoral, or it is proximal femoral, or it is distal femoral. So I will focus only on these areas. And before I read the question, what I know beta in the lower limb, that yes, there is a abdominal aorta, and abdominal aorta beta, quickly, abdominal aorta starts at the level of T12. There are three openings in the diaphragm beta. Voice of America, VOA, vena cava, esophagus, aorta, T8, T10, T12, 8, 10, 12, Voice of America, 8, 10, 12, Voice of America. एक बार बोलो बेटा फटाफट से, Voice of America, 8, 10, 12, Voice of America, 8, 10, 12, yes, 8, 10, 12, Voice of America. Okay, so aorta becomes abdominal at the level of T12. It extends up to L4 where it divides into right and left common iliac. Then common iliac divides into internal and external iliac. Internal goes towards the pelvis to supply the pelvic organs. External becomes the femoral, and this femoral continues down below the mid-thigh level, and then it becomes the popliteal. Popliteal divides into anterior tibial and posterior tibial. Anterior tibial in the foot continues down as the dorsalis pedis. So here, this would be the femoral, this would be the popliteal, this area would be the popliteal area. Here you can see the anterior tibial and the posterior tibial, and here in the foot, it would be the dorsalis pedis. Okay. Now here I would like to specify beta, these type of questions, they can be asked. They might give you two things in the exam, in the question. Where is the site of pain and which pulses are palpable, which are not palpable. Okay बेटा, दो चीजें ध्यान रखेंगे, किस जगह पे पेशेंट को दर्द हो रहा है और कौन सी पल्सेस पाल्पेबल है, कौन सी पाल्पेबल नहीं है. Okay. Now suppose if the examiner says that pain is in the calf or the leg region, है ना, तो that means the traffic jam should be just above the calf or the leg region. If the examiner says कि pain is in the calf, leg as well as in the thighs, so there should be a traffic jam in the femoral artery. Okay. If the examiner says that patient is having a problem in both the lower limbs, buttocks, gluteal region pain is there, pain in both the thighs, calf, legs, that means the traffic jam should be at the bifurcation of aorta, aortoiliac. Okay. So that is how on the basis of symptoms you have to identify the site of obstruction. Needless to specify beta, if suppose the calf or the leg pulses are not palpable, but the femoral pulse is palpable, that means the traffic jam should be just above the calf level. That means the distal femoral or the proximal popliteal level. If the examiner says that on the right, on one side, suppose all the pulses are not palpable in the lower limb on one side, the other limb, all the pulses are palpable, right? That means there has to be obstruction at the iliofemoral level, If the examiner says that pulses are not palpable in both the lower limbs, beta, then the obstruction should be at the aortoiliac level, right? So this is the concept. This image is ankle brachial pressure index measurement beta. This is a ABPI measurement. This is a handheld Doppler. This is the sphygmomanometer cuff. And here you can see the manometer, right? So this is how we can measure the ankle brachial pressure index to see the severity of arterial obstruction. Right, beta. So I have to just focus on what is the site of obstruction. I want two things. What is the site of pain and which pulses are palpable and which are not palpable, right? Okay, quickly let us take a look. Fine. Pain in the calf and the leg on the right side. Calf and the leg, fine. Aggravated on walking and exercise. Any arterial traffic jam pain will be aggravated on exercise. On clinical examination, beta, popliteal and distal pulses on the right side are absent, but the femoral pulse is palpable on the right side. Oh my God. So it is so clear cut, beta. Jaldi se batao, beta, popliteal distal pulses are absent, but femoral is palpable. है ना? Femoral is palpable, but popliteal and distal are absent. That means this is not the answer. Aortoiliac agar hota, to femoral would not be palpable. Iliofemoral में भी femoral would not be palpable. Proximal femoral में femoral would not be palpable. Distal femoral में femoral would be palpable because femoral pulse कहाँ पे feel करते बेटा? Where do we feel the femoral pulse? We feel it just beneath the groin crease, 2 centimeters below the mid-inguinal point, right? So if we are able to palpate this, that means the traffic jam is somewhere distal. Popliteal is not palpable, distal pulses are not palpable, femoral is palpable. So traffic jam should be somewhere between the femoral and the popliteal, okay? So the best answer for this question should be yes, everybody. Yes, beta. Very good. Wonderful. बहुत बढ़िया बेटा. Wonderful. That's really great. Saurabh, Vishal, Rizwana, Jitendra, Rajendra, Guna, Vicky, Mirdha, Shrishti. Perfect, beta. Perfect. Very good. So the correct answer should be distal femoral. And you are absolutely right. God bless you, beta. God bless you. This is how, beta, we need to apply the concepts in the exam. You know, on the exam day, many a times when we are having the anxiety, so we are not able to focus on identifying the keywords. दोबारा से बोलता हूँ बेटा, I'll speak this in Hindi also because this is crucial. जब हम एग्जाम हॉल में होते हैं ना बेटा, तो एंजाइटी की वजह से जो कीवर्ड्स होते हैं ना, उन पे शायद उतना फोकस मिस हो जाता है. अब जैसे अगर हमने इस क्वेश्चन को देखा है ना, तो इसमें कंफ्यूज नहीं होना है बेटा. अपने को दो चीजें पता करनी होती है, दर्द कहाँ पे हो रहा है और कौन सी पल्सेस नहीं मिल रही है, कौन सी मिल रही है. ठीक है ना. तो इसमें अब वो उसने लिखा femoral pulse is palpable. इफ अगर हमने इसको ऐसे पढ़ लिया होता कि femoral is also not palpable, तो हमारा आंसर हो जाता है इसमें आइलियोफेमोरल, और ये सिली मिस्टेक हो जाती बेटा हमसे, है ना. सो we just try to minimize the silly mistake beta. We have to read each and every word carefully. We should not misread this. Femoral is palpable on the right side. Why I'm saying so beta? Because sometimes it happens when you are coming out of the exam hall na beta, and when you are discussing the things after say second paper. फर्स्ट पेपर के बाद तो डिस्कस करना ही नहीं होता. सेकेंड पेपर के बाद when you are discussing with your friends and suddenly one of your friend tells you that, see, in that particular question they said femoral is palpable, and you start thinking no, in that particular question it was given that femoral is also not palpable. So these type of things beta, this is because of anxiety we misread it, and because of this we have marked it wrong. So just try to maintain a cool, calm composure inside you during the exam hall. That is very important. And try to read out all the keywords nicely. है ना? Fine. चलिए बेटा. Now let's look at another question here. This looks to be a little okay type of question. So let me read it. शुभम, एओर्टो आइलिएक में दोनों साइड होगा बेटा. एओर्टो आइलिएक में क्या होगा? सपोज देयर इज अ क्वेश्चन फ्रॉम शुभम. लेट मी क्विकली एड्रेस टू शुभम्स क्वेश्चन. शुभम बेटा, सपोज दिस इज द एओर्टा, राइट, एंड देन द एओर्टा डिवाइड्स इनटू राइट एंड लेफ्ट कॉमन आइलिएक, है ना, एंड देन दिस कॉमन आइलिएक फर्दर डिवाइड्स इनटू इंटरनल आइलिएक एंड एक्सटर्नल आइलिएक, है ना. तो इंटरनल हो गई ये दोनों, and then this is the external iliac, right? Now beta, this will become the femoral, right? Okay. If I say that there is a traffic jam in this particular area beta, if there is a traffic jam in this particular area, okay, so what is going to happen beta? Supply on both the sides is going to decrease now, so the patient will be having pain in both the lower limbs. समझ आया बेटा शुभम? Okay. Yeah. Fine. I hope you got it. Great. So now let's take a look at another question beta. 76-year-old woman. This is a small question, so let me read it from the beginning. 76-year-old. She is elderly, okay, for review of an ulcer that appeared 2 weeks ago. Okay, over the medial aspect of her lower left leg. Medial aspect of lower left leg, medial side. Okay, this is shallow ulcer with sloping edges. So beta, shallow sloping edges is seen in healing ulcer, inflammatory ulcers. Then undermined TB, punched out syphilis, raised everted squamous cell carcinoma, rolled out and beaded basal cell carcinoma. I repeat this beta quickly. The different type of edges: sloping edge is seen in healing inflammatory ulcers, undermined TB, punched out syphilis, raised everted squamous cell carcinoma, rolled out beaded basal cell carcinoma. Okay, so this looks to be a healing type of ulcer. There is hyperpigmentation of the surrounding skin. Okay, so medial side hyperpigmentation, this is something what we see in varicose veins complication. A venous ulcer is seen on the medial side of the leg. Lipodermatosclerosis, that is a brownish blackish discoloration of the skin with thickening of the skin, again a complication of varicose veins. And she takes warfarin for a previous recurrent DVT. Okay, so they have given the cause also. That patient would have had deep venous thrombosis because of which this has happened. Before we move further, beta, let us quickly try to understand this as well. For example, if we are talking about the lower limb, suppose I say, beta, that this is what I have made the lower limb here. And suppose this is the calf area and above is the thigh area. Okay. Now in our leg, beta, we have got a deep venous system and a superficial venous system. Deep venous system is deep within the muscles like the femoral, popliteal, tibial veins, and superficial venous system, beta, superficial is superficial just beneath the skin. So just beneath the skin, if I say suppose this is the medial side, right? Then we have got a great saphenous vein which is opening into the femoral vein like this, and there is a short saphenous vein which is opening into the popliteal vein like this. So this would be the great saphenous vein, this would be the short saphenous vein, and in the center there would be deep veins, right? Now what happens in varicose veins, beta? If suppose uh, the blood generally what happens move from superficial vein to deep vein, and there are valves which does not allow the blood from deep vein to come into the superficial vein. But people who are standing for long periods, or where there is a traffic jam, suppose in pregnancy the baby is sitting over the inferior vena cava, then inferior vena cava would be compressed. That means the blood from the deep vein will not be going nicely up. So there will be pooling of blood in the deep vein. More pressure in the deep vein will put more pressure on the valves here, and this valve can become incompetent. And if the valve becomes incompetent, then blood from the deep will start moving into superficial veins, right? So then these veins will become varicose, abnormally dilated and tortuous. And because they have become varicose, the blood will start pooling in the lower part, which may create ulcers and lipodermatosclerosis. Here they are saying deep vein thrombosis, beta. So if we say that suppose there is a deep venous thrombosis here, now what is going to happen in this case? There is a thrombus in the deep vein, blood will not be going up, blood will be pooling here. So all the blood will be going into the superficial through the perforators. There are perforating veins also. So he has also given us the cause of varicose veins. If we take a look at some of the images, beta, this is how the varicose veins looks like, the abnormally dilated tortuous veins. This is the lipodermatosclerosis, the brownish blackish pigmentation, the venous ulcer, which is seen around the medial malleolus in the gatus area. This ulcer can complicate into Marjolin's ulcer, which is squamous cell carcinoma, which can also be seen in burn patients. So these can be the different complications of varicose veins. Now let us take a look. What are the options? Is it an arterial ulcer? No. Is it a Marjolin's ulcer? It can be a Marjolin's ulcer. Is it a venous ulcer? Yes, it is a venous ulcer what he is talking about. Neuropathic ulcer? No. It is not something related to diabetes or something. He has given us the exact story of a venous ulcer. So the best answer for this particular question would be venous ulcer or a post-phlebitic ulcer. Okay, so the correct answer is post-phlebitic or venous ulcer. Okay, not nomadic Rakesh, it is not Marjolin's, beta, because it is only 2 weeks old. For Marjolin's ulcer, it will take years together for cancer to develop, right? Okay, fine. Let's have a big round of applause for all of you. Yes, inverted champagne bottle appearance is also seen in this varicose vein complication, what we saw. This is, what is this inverted champagne bottle? Let me just quickly point it out for you. This is how the inverted champagne bottle looks like. Champagne glass or champagne bottle appearance, you can say. Right? Fine. Now let's take a look at another question, beta. This also looks to be a small question. 18-year-old girl presents in the OPD. 18-year-old, freely mobile, firm lump in her left breast. Okay, so lump in the breast, beta, 18-year-old, less than 30 years of age. The commonest reason for lump in the breast is fibroadenoma, breast mouse. After 30 years of age, commonest reason for breast lump is an invasive ductal cancer. Okay, so first thought which has come to my mind is fibroadenoma. It is painless, no discharge from the nipple, least likely, beta. This is the important word here, least likely to be true. Oh, least likely to be true. Fine. That means he is asking what is false. Okay. Fine. Common in the given age group and usually regress by 30 years of age. Yes, fibroadenomas, they do develop in 15 to 25 years of age and generally can regress spontaneously by 30 years of age. This is something related to hormonal imbalance. Should be removed in case of suspicious cytology. Yes, fibroadenomas, if we are not able to establish the diagnosis that it is benign, if we are thinking that there is a possibility of malignancy, we should not leave it, we should excise it. Irregular speckled calcification on mammography is seen in breast cancer, while popcorn calcification on mammography is seen in fibroadenomas. So this statement looks to be false. It is hyperplasia of intralobular stroma in the breast. Yes, it is hyperplasia of intralobular stroma in the breast. So this is a true statement, this is a true statement, and this is a true statement. So the correct answer for this question would be yes, the C. Mammo, definitely nickel. It is not done in younger females, and the reason is because of the density of breast in young females is high. So mammo, we might miss the lesion on mammography in young females. Right. Popcorn, yes, is seen in fibroadenomas. Fine. Now another question. This looks to be a small question. A newborn baby is continuously pouring the saliva from the mouth. Newborn baby continuously pouring the saliva from the mouth. Why he is pouring the saliva from the mouth continuously? Might be a traffic jam somewhere here. Okay. On antenatal evaluation, polyhydramnios was there. Okay. So antenatal during pregnancy, there was polyhydramnios. Baby is suspected of having other anomalies as well. What should be the initial evaluation? Again, beta, I would request you with folded hands, beta. This is something which is crucial. The examiner is focusing on what is the next step, next step, next step, right? So we should know the stepwise approach. He is asking initial evaluation in this baby for frothing of saliva from the mouth. Now, simple to understand, beta. Why the baby is throwing the saliva out? Because of some traffic jam. Might be a traffic jam in the pharynx, might be a traffic jam in the esophagus. Okay. For example, esophageal atresia is something what we know about, beta. In esophageal atresia, there is absence of some part of the esophagus. This is due to posterior deviation of tracheoesophageal septum. Most commonly, it is the type C where upper esophagus is blind and the lower esophagus communicate with the trachea. Now, because this is blind, nothing from the mouth is going to go down, right? Nothing is going down, right, beta? So there is continuous frothing of saliva from the baby's mouth with risk of regurgitation, aspiration, and pulmonary complications would be there. How do we approach these babies, beta? We try to put a nasogastric tube. Will the nasogastric tube go into the stomach? Jayegi kya beta? Nahi jayegi. No. So there will be coiling of the nasogastric tube in the upper esophagus. That is how we get an idea that this baby might be having esophageal atresia. During pregnancy also, beta, whatever saliva is there in the fetal mouth that is not going down, that is continuously coming out from the mouth. So that is adding on to the volume of amniotic fluid, polyhydramnios, right? Okay. This is associated with congenital anomalies like VACTERL, vertebral, anorectal, cardiac, tracheoesophageal, fistula, renal, and limb defects. Once we have made this initial evaluation by nasogastric tube, we can take a chest x-ray. We'll see the coiling of the tube. And if it is a fistula also, then we'll see a distended stomach on x-ray. Fine. Best would be doing a CECT. And the treatment for this would be on day 1 or day 2 of life. We will divide this fistula and connect the lower esophagus with the upper esophagus, which is esophagostomy. Esophagostomy. Right, beta. So now let's take a look at what he's trying to ask us. What should be the initial evaluation for frothing of saliva? Okay. Are we doing CCT as initial? No. Chest X-ray? Yes, we do chest X-ray. Upper GI endoscopy? No, we are not doing endoscopy here. Nasogastric tube? Yes. So we are passing the nasogastric tube. Because Dr. C.P. Mewara, CCT is the best, but not the first. Initial he is asking, right? So nasogastric tube would be the best answer for this question, right? Acha beta, now this is a simple question, I guess. Image based question. Jaldi se batao beta, what is this? Yes. This is a hot image based question, na beta. This is pancreas. Can you see this ring of pancreatic tissue? Yes, fine. So, what is this? The options are colocolic, intussusception, Meckel's, annular pancreas, choledochal cyst. It is a clear-cut case of annular pancreas, right, beta? Nikhil, Samsung, Saurav, Rajak, Vinta, Charat, Augustine, Shubham, Shivam, Saurabh. Wonderful, wonderful, wonderful. Everybody has answered this correctly. Yes, FMG favorite question, Shubham. Very good. So the correct answer for this question is annular pancreas. Perfectly done, beta. God bless you all. Wish you all the very, very best. ऐसे ही बस लगे रहो, हिम्मत हारनी नहीं किसी भी moment पे. We don't have to lose our faith in ourselves. We have to keep on believing in ourselves. Yes, I will do it. Come what may, I will do it. I know what is going to be my plan, and yes, I will do it. बहुत बढ़िया बेटा, बहुत बढ़िया. Mathan, Bhargav, Khwaja, Prahlada, perfect. Fine. Now another question here, beta. Claw sign in ileocolic intussusception is seen on which of the following investigations? Okay, now this claw sign is again a hot question. What is intussusception, beta? Intussusception is simply invagination of one part of the intestine into the adjacent part. Most commonly seen at around 6 months of age due to hypertrophy of Pierce patches. And the peristalsis forces the thick ileocecal region to move up, and baby presents with a sausage lump in the right hypochondrium, concavity directed towards the umbilicus. The baby may pass red currant jelly stools, and when we are examining this baby, there is emptiness in the right iliac fossa, which is called as sign of dance. And when we put our finger into the rectum of this baby, the examiner's finger is stained with blood. Since the baby is presenting with a mass in the right hypochondrium, the first investigation what we are doing is a ultrasound. Very good. B. Yes, absolutely correct, beta. Absolutely correct. Just have a look at these different findings, what we see in intussusception. The first investigation is an ultrasound where we see a donut sign. In a donut sign, there is an inner tube, and then there is an outer tube. So that is why we call it as donut. On X-ray, beta, we find a crescent sign or a meniscus sign. Crescent sign or a meniscus sign. Okay, there is a sausage lump in intussusception. And on barium enema, beta, we see this wonderful claw. This has been asked as a image-based MCQ as well. Can you see this claw, beta? The terminal ileum is tightly fitted into the cecum here, and when it is too tight, when we are giving the contrast from below, all the contrast is getting holded up into the cecal area. No contrast is going into the terminal ileum, and that is why we are seeing this claw here. However, if there is some space between the terminal ileum and the cecum, the contrast will form rings around the terminal ileum, which we call as coiled spring sign in intussusception on barium enema. Best investigation for intussusception is CECT of the abdomen, and the treatment is hydrostatic reduction by air enema. We can even use saline. Wonderful. So again, this intussusception is going to be a hot topic for you. So claw sign in intussusception is seen on barium enema. That's absolutely correct, beta. Fine. Now another image based question, and for the image based question, beta, first we have to look at the image. I hope all of you have got this. Yes, beta, there are two type of x-rays, you can say, illegal A7. One is a plain x-ray where we are not using any contrast, and another is a contrast x-ray. And when we are using the contrast in GIT, we generally prefer using barium. To study the esophagus, we do barium swallow. To study the stomach, we do barium meal. To study the duodenum jejunum ileum, we do a barium meal follow through. And for the colon, we do a barium enema. Perfect, beta. So every one of you are correct. This is horseshoe kidney. Richa, Vincent, Nikhil, Pukhraj, everybody. Handshake sign. Very good, very good, very good. Pratibha, Akash, Thanga Prakash. Okay, beta. Now let's take a look at the question, what he's trying to ask. Which of the following is not true? Not true about 5-year-old girl presenting with the repeated episodes of urinary tract infection and CCT following images seen. Okay, beta. So horseshoe kidney. Horseshoe kidney, what we know about is this is something when during intrauterine life, what is happening? During intrauterine life, when both the kidneys, they are ascending upwards. Now what happens? There is an inferior mesenteric artery at the level of L3, and that arrests the ascent. The lower poles of the two kidneys, they fuse in midline, and now this results in a pair of ectopic kidney. The kidneys cannot ascend upwards into the lumbar region. The level of isthmus here is L3, L4. Generally the patients are asymptomatic, but sometimes complications can occur because of traffic jam in the ureters on both the sides. There may be UTI, stone formation. The treatment generally is just treat the complications, because if we try to separate both the kidneys, we have to divide the isthmus. There are 3 solid organs in your abdomen: liver, spleen, and kidney. Whenever they are injured or whenever we incise them, they bleed profusely. So to avoid that profuse bleeding, we just try to treat the complications at the first instance, and we do not divide the isthmus on a routine basis. So division of isthmus is not the treatment of choice here. Is it a pair of ectopic kidney? Yes, it is a pair of ectopic kidney. CCT is the investigation of choice. That's correct. Can develop urinary tract infection and urinary stones. That is also correct. And surgery is the preferred treatment of choice. No, this is a false statement here, my dear friends. So absolutely correct, all of you, beta. D, surgery is the preferred treatment of choice. This is a false statement. Right. Now another question here. This is again going to be a very, very hot topic for you. This is a small question. 7 months old male baby presented with empty scrotum. On examination, the right testis was found in the perineum, while the left testis was found in the inguinal canal. Correct about the diagnosis in this baby. Now look at me, beta. Be careful. Herein, during intrauterine life, we know there is a inguinal canal here, and the testis follow a standard path of descent. Suppose this is the normal path of descent of the testis. Just before birth, the testis drop down to the bottom of the scrotum. This is normal. Now what I'm trying to tell you, beta, if the testes are arrested anywhere in the normal path of descent, even at the top of the scrotum, then we call them as undescended testes. But if the testes deviate from the normal path and come to lie somewhere else, then we call them as ectopic. I repeat this in Hindi, beta. अगर टेस्टिस अपने नॉर्मल रास्ते में कहीं पे अटक जाती है तो अनडिसेंडेड, भटक जाती है तो ectopic testis. Okay. Now, undescended testes most commonly are seen in the inguinal canal. Ectopic testes are seen in the perineum, at the root of penis, or maybe in the femoral canal, right? Superficial inguinal pouch, Dennis Brown pouch is the commonest site for ectopic testis. Retractile testis is something where the testes have nicely descended, but when you are eliciting the cremasteric reflex, the testis may ascend up into the inguinal canal. But if it is possible to manipulate the testes and bring them down to the bottom of the scrotum, just by simple manipulation, they are called as retractile, and retractile will not require any treatment. Okay, so herein what the examiner is saying is that the right testis in the perineum, that means right is ectopic, and left in the inguinal canal, that means left is undescended. So out of the given options, beta, right ectopic and left undescended. Fine. Everybody is correct, beta. Wonderful. So the correct answer for this question is right ectopic and left undescended. Now this is again a hot area from where you can get the questions. Now moving further, beta. This also looks to be a small question. So let me just go through this. 65-year-old elderly person, binge drinking. Now beta, this binge drinking is actually used by the examiner commonly in the last 2 years. Pichle 2 saal se they are using this term binge drinking. Okay, that means huge amount of alcohol has been taken by the patient. After heavy meals, the patient vomited terribly and presented with hematomas. Hematomas. You are the doctor, you have stabilized the patient, investigated the patient, most likely pathology in this patient. 65-year-old, binge drinking and heavy meals, the stomach is full. The stomach will forcefully contract for vomiting, and suddenly the contents will be released up under pressure. There can be two things, beta. This is the inside view of the stomach. Now, if suppose there is forceful vomiting, what is going to happen? Because of the high pressure, this can cause a mucosal tear in the stomach. Mucosal tear in the stomach, just below the gastroesophageal junction. This what you are seeing here, beta, this is the gastroesophageal junction. Okay, so this is the mucosal tear which will bleed and patient will present with hematomas. Sometimes what can happen, beta, when the stomach is contracting forcefully after heavy meals and binge drinking, the intragastric contents are released up into the esophagus under pressure. The weak esophagus, the elderly esophagus cannot tolerate such high pressure and the esophagus can rupture. This is a transmural esophageal rupture. All the gastric contents will be released into the mediastinum under pressure, leading to mediastinitis, sudden onset of severe left-sided chest pain radiating to the left shoulder and the left arm. Right? So this is the presentation in Bohr-Harvey syndrome, Bohr-Harvey syndrome or barotrauma. तो ध्यान रखना बेटा, Mallory-Weiss tear is only mucosal tear in the stomach which bleeds, hematomas. But Bohr-Harvey syndrome, it is the transmural lower esophageal rupture where the gastric contents are released into the mediastinum under pressure. Okay, so hematomas, out of these two, I feel Mallory-Weiss should be the best answer. Emphysematous bulla rupture, the examiner has not given anything related to pneumothorax. Duodenal ulcer, bleed from gastroduodenal artery. Yes, the patient can present with hematomas in duodenal ulcers, but most often they present with melena. Okay, here they are classically giving you the history of binge drinking and heavy meals. So this is something which is more likely associated with pressure situation due to vomiting. So we are focusing on Mallory-Weiss and Bohr-Harvey. The correct answer for this question, yes, beta. Right. So the answer for this would be Mallory-Weiss. Afsal, very simple, beta. Please try to avoid any confusion. If it is just a mucosal tear, it is going to bleed. Blood will get collected in the stomach now. So this blood will be coming out in vomiting, hematomas. Hematomas, Mallory-Weiss. If the esophagus ruptures, then the patient will present with left-sided chest pain. There would be subcutaneous emphysema, right? So that is what is Bohr-Harvey. There is no hematomas here in Bohr-Harvey. and there is no left-sided chest pain in Mallory V steer. Okay, so just try to keep themselves separate. I hope, Kajal, you've got it now. Gastric antral ectasias, watermelon stomach. That is just the ectasias, dilatations of the antral vessels. Okay, beta. Now this is again a hot image-based question. I hope every one of you knows this answer. Let me have the answer from all of you. What is the answer for this? Raj Lakshmi, yes, no hematomasses in bore Havi beta. Can you see this classical tapering beta? What is this? Yes, illegal A7. You're the first one. Okay, so you have already read the question earlier. Fine. Yes, so every one of you is correct. This is eclasia cardia. Why I included this image here is because this is a very, very hot question commonly asked. Just have a look at these further more images. This is also an image of eclasia cardia beta, the classical bird beak or pencil tip appearance. There is just a thin rim of contrast flowing down, which you can call as rat tail appearance. Here also you are seeing the same story, the pencil tip or the bird beak, the rat tail appearance. And this, my dear friends, this is actually a case of cancer. It is not a classical bird beak, okay? It is not a classical bird beak. There is a cancer sitting over here and only a thin rim of contrast is going down, okay? So this would be cancer esophagus, this image. While this image, again a very hot image-based MCQ beta, all of you know this is a corkscrew esophagus, a diffuse esophageal spasm. So this is a hot area from where we can get the image-based question in the exam. Right, so the correct answer for this question is eclasia cardia. Now another image-based question here. Can you tell me beta, what is this? This is the chest X-ray, this is abdominal X-ray here. Now here this white line, what you're seeing here, this is the diaphragm and you are seeing some black shadow beneath the diaphragm. This is the gas under diaphragm, okay? Here also in this particular image beta, if you carefully take a look, can you appreciate the white diaphragm here? This what you're seeing, this is the diaphragm. And can you see some black shadow here? Now this is what we call as the gas under diaphragm, this particular thing, right? Okay. Now here also you are seeing some gas. This is actually the stomach fundus shadow, which is normal, okay? So this is normal, but this is pathological. We always try to look beneath the right dome of diaphragm. Yes, absolutely correct. This is a pneumoperitoneum, may be seen in peptic ulcer perforation. Absolutely correct beta. So this is again a hot image-based MCQ. If I take a look at the options, obstruction, empyema, acute cholecystitis, and hollow viscous perforation, I feel this hollow viscous perforation is the best answer. Let me quickly take a look at the last line. What will be the most likely diagnosis? Most likely diagnosis. So the answer for this question should be hollow viscous perforation. Let me read the question quickly. Mr. X, 36-year-old, presented to emergency. Sudden onset of pain all over the abdomen, nausea, vomiting for the last 2 days, pulse rate 110, systolic BP 100, diffuse abdominal tenderness, guarding and rigidity. Basic resuscitation was done. So this is a clinical picture of peritonitis, what they have mentioned. So for me, yes, the correct answer is hollow viscous perforation. Now, my dear friends, another question here. Right. Now, in this particular question, what is the most likely diagnosis he's asking about? And all 4 options, he's saying acute, 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 cholecystitis, pancreatitis, appendicitis, cholangitis. Okay. So let us quickly take a look and try to understand better. Gallbladder cholecystitis. The patient would present with sudden onset of severe pain in the right upper abdomen, which would be radiating to the back, that is inferior angle of right scapula, and sometimes to the tip of the right shoulder, associated with anorexia, nausea, vomiting, and sometimes even fever. Acute pancreatitis would be presenting with upper central abdominal pain radiating to the back, maybe from the right side or from the left side, and this pain would be aggravated in lying down position. So these acute pancreatitis patients, because pancreas is retroperitoneal, these patients prefer sitting, leaning forwards. Then appendicitis. We know the classical pain in appendicitis, it is periumbilical, which shift or migrate to the right iliac fossa. Okay, fine. And acute cholangitis. Cholangitis is inflammation of the common bile duct. Cholecystitis, beta, it is gallbladder. Cholangitis is bile duct, right? So acute cholangitis would also present with sudden severe pain in the right hypochondrium. Okay, fine. Now in cholecystitis, we find a Murphy sign, acute cholecystitis. If we try to insinuate the forefingers beneath the right costal margin and ask the patient to take a deep breath, patient suddenly catches her breath. This is Murphy sign seen in acute cholecystitis. While McBurney's sign is tenderness in the right iliac fossa at the McBurney's point seen in acute appendicitis. If we take a look at the question here, there is severe right upper abdominal pain, nausea and vomiting, pulse rate 100, temperature 102.4. Okay. Okay. Investigations showed. Now, what can be this problem, beta? Right upper abdominal pain, severe right upper abdominal pain. Out of the given options, yes, acute cholecystitis and acute cholangitis. So I have ruled out these two. Okay, now I have to just focus on the A and D options. The temperature is there. Investigation showed total leukocyte count is high. Differential count raised neutrophils. It is acute inflammation. SGOT, SGPT looks to be just at the higher side of normal. And alkaline phosphatase is markedly elevated. Now, alkaline phosphatase will be elevated in which condition, beta? Whenever there is obstructive jaundice, then the alkaline phosphatase will be elevated. So now tell me, my dear friends, this obstructive jaundice will be seen in cholecystitis or cholangitis. Yes, you're right. So this is cholangitis and not cholecystitis. Perfect, beta. If you carefully take a look at this question, the famous Charcot triad, pain, fever, jaundice, pain, fever, jaundice, pain, fever, jaundice, Charcot, cholangitis. This is what is given in this question. So for this, the correct answer will be acute cholangitis, right? That is how you will segregate between the different acute abdominal conditions. And I feel that yes, you're going to do it. Now again, image-based question, beta. In this particular question, if we take a look, if this is the umbilicus, suppose, now we are seeing something around the umbilicus. This is a bluish discoloration seen around the umbilicus. Yes, let me just have a look. Wonderful, wonderful. Great. Love you too, beta. Yes, so yes, everyone, what is this bluish discoloration around the umbilicus? Come on fast. Yes. Acute pancreatitis, Cullen sign. Perfect, perfect. Very good. Now let's take a look at the question. Let me look at the options. Diverticulitis of colon, pancreatitis, hemorrhagic pancreatitis. Oh my God, what is this? There are two options of pancreatitis, my dear friends. Acute pancreatitis and acute hemorrhagic pancreatitis. Oh, third option is also pancreatitis. This is chronic pancreatitis. Now what is this? This is Cullen sign, yes. Okay. Fine. Now let's just take a look at the question quickly. 48 years old, presented in the emergency room with severe central upper abdominal pain radiating to the back, pain aggravated in supine, relieved on bending forwards, bluish discoloration. The same story. Now we have to identify whether it is acute pancreatitis or acute hemorrhagic pancreatitis. My dear friends, this bluish discoloration, whether it is a Cullen sign around the umbilicus or great renal sign around the flanks, mark my words, hemorrhagic pancreatitis would be a better answer than simple acute pancreatitis. What actually happens when the enzymes are eating up the pancreas, when the enzymes are causing necrosis of the pancreas, the blood vessels are also getting eroded, and this blood that trickles down and comes anteriorly, when it gets collected around the flanks, this is great runner, and when it collects around the umbilicus, this is the Cullen sign. So my dear doctors, please remember, he has given this option before hemorrhagic pancreatitis. So this can be a silly mistake. The best answer for this would be hemorrhagic pancreatitis. Hemorrhagic pancreatitis. Okay? Be careful. This is how we have to avoid the silly mistakes. We have to read all the 4 options carefully. Fine. Now let us take a look at this. This looks to be a small question. Which of the following is not likely to be a complication for the ideal treatment done for a 33-year-old male diagnosed with 2 centimeter stone in the left kidney? Okay. Which of the following is not likely to be a complication for the ideal treatment done for a 33-year-old male diagnosed with 2 centimeter stone in the left kidney? So what are the different options first in the treatment of urinary stones? If we take a look, my dear friends, now here what we are seeing. The treatment of choice for kidney stones is ESWL. What we are doing in ESWL, beta, we are firing the shock waves directly onto the stone, and this is causing the stone to disintegrate into small fragments. As you can see here, the stone is broken into small fragments, and then these will pass spontaneously in urine. This is how shock waves break the kidney stones. But a bigger stone, like more than 1.5 centimeter kidney stone, we avoid shock waves, and the simple reason is that when the stone will be fragmented, when the stone will be broken, if suppose any fragment of the stone is more than 5 millimeter, then the diameter of ureter is only 6 to 8 millimeter. If a fragment or a broken stone is more than 5 millimeter, it may get arrested in the ureter. Okay, that is why more than 1.5 centimeter stones, it is better to deal with PCNL. Now in PCNL, beta, this is percutaneous nephrolithotomy. Make an incision on the skin, create a tract up to the pelvic ileal system, pass an endoscope through this, and then you can just remove the stone through this, and this is what is called as PCNL. When we are doing a PCNL, that means for a 2 centimeter kidney stone, we are doing a PCNL. We go via the 12th rib approach. Common complication is bleeding. Apart from this, there may be urinary extravasation, urinoma, urine collection in the retroperitoneum. There may be injury to the spleen or the colon, or sometimes even to the pleura, but not to the lungs. The lower border of pleura is at 8, 10, 12. At the posterior axillary line location, the pleural lower border is at T12. The lung lower border is at T10. So pleura 8, 10, 12. Lung lower border 6, 8, 10. So when we are going via 12th rib approach in PCNL, we may injure the pleura but not the lungs. Okay. And this procedure, what we are seeing, beta, this is a ureteroscopic retrieval of stone. If there is a stone in the lower ureter, we pass a ureteroscope. Through the side channel, we pass a Dormia basket, and with the help of this, we can retrieve the stone. Fine. Now let us see which is not likely to be a complication for ideal treatment of 2 centimeter kidney stone. Ideal treatment for 2 centimeter kidney stone is PCNL. So he's asking which is not a complication of PCNL. Hematuria, it is a common complication. Urinary extravasation is also common. Spleen colonic injury is also common, but lung injury is not there. So if we take a look at the correct answer, yes, the correct answer is injury to lungs. Fine. Now, if we move to another, this looks to be a lengthy question. So let me read it nicely. Yeah. The last line is, what would be the most likely pathology in this patient? Now, beta, instead of deviating to 10 pathologies, we'll focus only on the 4 given options. He is saying liver abscess, appendicular abscess, acute appendicitis, appendicular mass. So 3 pathologies are related to appendix: acute appendicitis, abscess, mass. Okay, now let's read. He's asking what is the likely pathology. 20-year-old male, emergency, history of pain in the right iliac fossa for 5 days. Now, right iliac fossa, that means liver abscess has been ruled out. Most likely it should be related to appendix. And here he is saying that 5 days. Now, 5 days. Okay. Patient was taking medicines from local doctor in the village but was not getting relieved of his symptoms. He stated that in the beginning pain was around the umbilicus, but later he started having pain in the right lower abdomen. On examination, a mass was felt in the right iliac fossa. He was admitted in the hospital for IV fluids, antibiotics with close observation and monitoring. That means he was offered Ochsner-Sharon regime. He was offered the Ochsner-Sharon regime. Right. So this is something what we are doing for appendicular mass. So the correct answer should be appendicular mass. For appendicular abscess, what we do is extraperitoneal drainage. Extraperitoneal drainage. Right. Perfect. Right. Now, a patient presents with a groin swelling which shows positive cuff impulse. Beta, groin swelling with a positive cuff impulse. क्या होगा ये? What would... Right. Swelling is reducible. On examination, swelling appear to be protruding out through the Hesselbeck's triangle. This belongs to which Niehaus category of hernia? Oh, so he's asking the Niehaus category. Let us quickly go through this Niehaus category here, beta. Now herein, if suppose this is the inguinal canal, and here suppose are the inferior epigastric vessels, we know there is a deep inguinal ring, here, and a superficial inguinal ring here. If the hernia protrudes out through the deep inguinal ring from this area, this is an indirect inguinal hernia. While if the herniation occurs directly through the Hesselbeck's triangle from this area, this is a direct inguinal hernia. Okay. So here in the given question, it is a direct inguinal hernia. Now let us see the Niehaus classification, beta. 1, 2 indirect, 3A direct, 3B both, 3C femoral, 4 recurrent. Can you repeat this with me, my dear friends, quickly? 1, 2 indirect, 3A direct, 3B both, 3C femoral, 4 recurrent. 1, 2 indirect, 3A direct, 3B both, 3C femoral, 4 recurrent. 1, 2, 3A, 3B, 3C, 4, perfect. Very good, beta. So a direct inguinal hernia belongs to category 3A. So here the correct answer would be 3. Right. The correct answer is 3. Perfect. Great. Now if you take a look, We are almost coming on to the last section. We are starting with oncosurgery discussion. Maybe 4 questions would be there, 4 or 5 questions maybe. This is a small question. 65-year-old male presented in the OPD with difficulty in swallowing the food for the past 1 month. That means dysphagia for 1 month. 65-year-old, barium swallow, filling defect, and rat tail appearance. That means barium swallow has been done. 65-year-old lady beta, you're sitting in the hospital in the OPD, right? Dysphagia, 65-year-old lady, barium swallow has been done. Filling defect is there, rat tail appearance is there, cancer esophagus is suspected. What is the next step in the evaluation to make the diagnosis in this patient? So beta, how do we approach the different malignancies? Just to simplify the oncosurgery concepts for you, the first investigation will always depend on how the patient has presented to you. ध्यान रखना बेटा, कोई जब भी आप हॉस्पिटल में प्रैक्टिस करेंगे, देखिए 4 जून को आपको लाइसेंस मिलने वाला है। दुनिया की कोई ताकत आपको इस लाइसेंस से रोक नहीं सकती। 4 जून को आपको ये लाइसेंस मिलने वाला है, बस हिम्मत रखना है। और जब ये लाइसेंस मिलेगा, जब आप हॉस्पिटल में प्रैक्टिस करेंगे अगस्त 2022, you will be wearing a white coat and a stethoscope around your neck. Depending on how the patient is presented, your first investigation will be according to that. For dysphagia, we are doing a barium swallow. For any abdominal masses, we are doing ultrasound of the abdomen. For any patient coming to us with jaundice, first we are doing liver function test. For any bleeding, blood discharges from the openings here and there, especially in elderly people where we are suspecting malignancy, the first investigation is evaluation of that blood discharge to rule out malignant cells. For example, 70-year-old gentleman presenting with painless hematuria, the first investigation will always be urine cytology to rule out malignant cells. Okay? First investigation will depend on presenting symptom. याद रहेगा बेटा. Now next, if you have got a clue, then you go to the diagnostic investigation, and wherever we can take a biopsy without risking the spillage of cancer cells, without causing the risk of dissemination of the cancer, if you can take the biopsy, that is the investigation of choice. And once you have made the diagnosis of a cancer, then you do the staging investigation. You want to know how far the cancer has spread. Like, which staging investigation, whether we should do a CCT or MRI. Now, my dear doctors, for staging, if you want to study the nerves, muscles, or the vessels, like in this particular area, we do a MRI. For breast, we do MRI. But for thorax, abdomen, we do a CCT. For pelvic area, again the muscles are there, we do MRI. So my dear friends, for staging, what we are doing, oral malignancy, we are doing MRI, breast we are doing MRI, but esophagus we are doing a CCT, stomach CCT, colon CCT, rectum is in the pelvis, MRI, bladder cancer staging, MRI, prostate cancer staging, MRI, penile cancer, MRI, anal canal cancer, MRI, staging investigation. Or if you want to know the distant metastasis, the gold standard investigation for distant metastasis is a PET scan. What is the name of the isotope used in PET? Quickly come out. Yes, that is 18-fluorodeoxyglucose. 18-fluorodeoxyglucose. Perfect. Great. For GI malignancies, if you want to know the depth of tumor, whether it is going into submucosal muscle or serosa or adventitia, you can do an endoscopic ultrasound. Okay, now let's take a look at this question. Dysphagia, barium swallow, filling defect, rat tail, esophageal cancer most likely. What next? I want to take a biopsy, and if I have to take a biopsy, I would be doing upper GI endoscopy. Endoscopic ultrasound to know the depth, but once let me prove that it's a cancer. Chest x-ray, no. CECT, I'll be needing this for staging purpose. upper GI endoscopy and biopsy. Yes, I'm going for this upper GI endoscopy and biopsy. So the correct answer, my dear friends, would be upper GI endoscopy. Right. Now this looks to be an image-based question. There is something which I can see around the umbilicus. Some nodule type of thing is seen around the umbilicus. Let me look at the options here. Fine. This is all related to metabolic abnormality. Acidosis, alkalosis, alkalosis, acidosis. So I have to see whether it is metabolic acidosis, alkalosis. Hypokalemia, hypokalemia, hyperchloremia, hypokalemia. And there is hypokalemia here also. So in all four options, there is hypokalemia. So I'm not going to intervene in potassium. Hypochloremia, hypochloremia, hyperchloremia, hyperchloremia. That means I have to just focus on whether it is acidosis, alkalosis, or hypochloremia or hyperchloremia. Now, let me see the question because I am not able to identify exactly what is this. Let me read the last line. Which of the following metabolic abnormalities most likely? Okay. Now I have to read this question. 70-year-old lady, projectile non-bilious vomiting in the emergency. Projectile non-bilious beta. Non-bilious vomiting, non-bilious. That means it is a case of gastric outlet obstruction. She is having anorexia, weight loss since last 2 months. There was a lump in the epigastrium along with nodules around the umbilicus. Rehydration electrolyte correction was done. Which of the following metabolic abnormalities most likely in this lady? Oh, so in gastric outlet obstruction, what I know, beta, if there is any traffic jam here, suppose there is a traffic jam in this particular area. Now what is going to happen? All the acid, whatever acid is there here, that acid is going to come out in vomiting. Okay, so acid is going to be lost. So there will be metabolic alkalosis. Metabolic alkalosis. That means this option and this option. This is gone, this is gone. Chloride is lost. So the chloride level will be low. So hypo and hyper. So obviously this is not the answer. So this will be the answer. So for me, the correct answer will be hypochloremia. Right? Now this question particularly, beta, this can be asked in a small baby, giving you the reference of hypertrophic pyloric stenosis, 17-day-old baby presenting with non-bilious vomiting, or they may give you a 40-year-old, 45-year-old gentleman, peptic ulcer disease, proton pump inhibitors, ulcer has healed, caused gastric outlet obstruction, non-bilious vomiting, or this 70-year-old lady, gastric outlet obstruction, gastric cancer, that mass has caused traffic jam at the pylorus. Okay, whatever it is, if it is a gastric outlet obstruction, you will find hypochloremia and metabolic alkalosis, and there is a paradoxical aciduria as well in these situations. So please be careful, beta. Yes, Apurv, you are absolutely correct. This is Sister Mary Joseph nodule. Fine. So the correct answer is hypochloremic, hypokalemic, metabolic alkalosis. Now, this also is an important area from where you might get a question regarding treatment of prostate cancer. Okay. 68-year-old male, prostate cancer, confined within the prostate. There is no extension beyond the prostate capsule, no evidence of metastasis. His daily routine is active and is physically fit. As a doctor, what will be your best treatment option in this patient? So here in beta, I would just like to remind you about some important steps in treatment of prostate cancer. This is going to be a hot area for 4th of June 2022, treatment of prostate cancer. Okay. Now, if suppose the cancer is confined within the prostate, the approach, or if the cancer has gone beyond the prostate, We know prostate is the most common cancer spreading to bones. If it is confined within the prostate, beta, there are two things. If the age is less than 70 years or life expectancy is more than 10 years, versus if the age is more than 70 or life expectancy is less than 10 years. Now, if this is the case, we prefer radical prostatectomy. Radical prostatectomy, which is being done by robot nowadays. But if the age is more than 70 or life expectancy less than 10, then we just do active surveillance. And the simple reason we keep on following these patients is that prostate cancer is the slowest growing cancer. अगर किसी दिन भगवान सपने में आए और बोले कि मुझे तुमको एक कैंसर देना ही देना है, मांग लो तुम्हें कौन सा कैंसर चाहिए, तो भगवान से प्रोस्टेट कैंसर मांगना चाहिए, ऐसा किताबें लिखती हैं. Now, since this prostate cancer is a very slow growing cancer, some people say this is a part of aging also. So if the cancer is still confined within the prostate, it might be very slow growing cancer. Just need to follow up these patients actively. But if the cancer has gone beyond the prostate, now we have to just go for palliative treatment of androgen ablation. Hormonal therapy. Hormonal therapy is useful in breast and prostate cancer. Breast cancer anti-estrogen, prostate cancer anti-androgens. For androgen ablation, beta, we can either give medicines or we can do surgical. In medicines, beta, we can give LHRH agonist like goserelin. Now, this question has been asked, you can say this is the pharma question of goserelin. And in surgery, we do bilateral subcapsular orchidectomy. Bilateral subcapsular orchidectomy. So that is how we are dealing with these treatment. There are other medications also. Medical castration is considered better. This is a Da Vinci robot image, which is used in robotic surgery. So for this particular question, the age is 68 beta. He is absolutely fit, right? Cancer is confined within the prostate. That means the patient is falling under this category. So the treatment obviously will be radical prostatectomy. Yes, absolutely right. Osteoblastic secondaries to the lumbar vertebra. Very good. Now the last question what we are seeing here for today's session. This is a 65-year-old lady, invasive ductal breast cancer, stage T2, N2, M0. On histopathology, estrogen progesterone receptors are positive. HER2 new gene is also positive. Possible best treatment in this patient recommended by you. So before we discuss all these different options, let us quickly take a look at the breast cancer staging and the treatment. So beta quickly, the TNM staging is what we are using always. T1 less than 2 centimeter, T2 is 2 to 5 centimeters, T3 is more than 5 centimeter, T4 is any size. But if there is involvement of chest wall, it is T4A. Involvement of skin is T4B. Involvement of both is T4C. And inflammatory cancer is T4D. So this is the T staging beta, and the lymph node staging is for the ipsilateral lymph nodes. Ipsilateral means the same side lymph nodes. If they are mobile axillary, it is N1, fixed axillary N2A, internal memory N2B. N3 is both apical and axillary. N3B is axillary and internal memory both. N3C is supraclavicular, and this is for ipsilateral lymph nodes. M1 is distant metastasis. Based on this beta, we can classify these breast cancers into early breast cancers if it is T1 or T2, N0 or N1. We can classify them into locally advanced breast cancers, where it is T3 or T4, N2 or N3, but M is 0 in both. And metastatic breast cancers, in metastatic breast cancers, it may be any T, any N, but M1. Now, what are the different options to fight against breast cancer? Surgery, chemo, radio, hormonal, and targeted therapies. Surgery, we can do a modified radical mastectomy, which is the commonest surgery done for breast cancer. We can do a simple mastectomy if lymph nodes are not involved. We can do a breast conservative surgery depending on the patient's wish or maybe the tumor size. But whenever we are doing breast conservation, taking a 1 millimeter or a 1 centimeter margin, then we have to give adjuvant radiotherapy with BCS. In chemotherapy, we can use various agents, the taxanes, the adriamycin, the cyclophosphamide. Hormonal therapy has to be given in all patients with ERPR positive. Premenopausal, we give SCRM tamoxifen, and postmenopausal, we give aromatase inhibitors. Targeted therapy, if HER2 gene is positive, we give trastuzumab. Okay, so depending on this, we can plan the different surgeries. For locally advanced breast cancer, the recommended guidelines are neoadjuvant chemotherapy, followed by modified radical mastectomy. Then, depending on whether hormone receptors are positive, you give hormonal therapy. Whether HER2 receptors are positive, you give targeted therapy. And radiotherapy also depends on whether any tumor resection margins, the specimen margins are positive or not. So for this case, which is a T2 N2, that means lymph nodes are definitely involved. T2 must be a 2 to 5 centimeter malignancy. So I can either go for modified radical mastectomy. Before that, I may go for a neoadjuvant chemotherapy if the breast size is small and the tumor is 4 or 5 centimeters in size. And since hormone receptors are positive and she is a postmenopausal lady, I'll go with aromatase inhibitors. HER2 is positive, I'll be using trastuzumab. Simple mastectomy is ruled out because lymph nodes are involved, so you have to remove the lymph nodes. Neoadjuvant chemo, modified radical mastectomy, aromatase inhibitors, and trastuzumab, yes. Breast conservative surgery with X-ray lymph node dissection, yes. I can go ahead with this also. With radiotherapy, yes. Trastuzumab, but I think hormone therapy is missing in this, so I'll still go ahead with the B answer. Chemotherapy, aromatase inhibitors, and trastuzumab. Surgery is missing in this option, so I'll still not go with this option, and I'll go with the answer B. Right, so the best possible answer in this particular case is B, though even if we would not have given neoadjuvant chemotherapy, I would have gone ahead with modified radical mastectomy, aromatase inhibitors, and trastuzumab. And herein, the question which have been repeated twice in our exam, in the last two exams, best prognosis breast cancer is luminal A. Luminal A is when ERPR are positive and HER2 is negative. Luminal B is triple positive, all three positive. HER2 enriched, only HER2 positive, and basal triple negative, all three are negative. Best prognosis is luminal A, where ERPR are positive, HER2 is negative. So beta, this is all about what I could do to summarize the important topics from where the MCQ people are picking up the questions. Hope beta, this might have helped you. Before I conclude, I would like you to give you some more planning regarding this. Just give me a moment. Just give me a moment. Right, beta. So now After this, I would like to focus on few important things. What actually you want to achieve, why we are sitting here right at this point of time. Thank you, beta. Thank you very, very much. Just give me another 5 to 7 minutes. And what we all are sitting here for is we want to crack this 4th of June, right? Quickly, we all know there will be 300 questions, 2 papers, 150, 150. First paper, the basic subjects. Second paper, the clinical subjects. What type of questions are going to be there? 20% would be the golden facts of the single liners, 60% the conceptual questions, which would be the game changer or the decider with the knowledge what you have gained, and 20% would be relatively difficult question. So we'll be targeting the 20% easy questions and the 60% game changer questions. That means 80% of the questions. And we believe that 20 to 25% questions are going to be image-based questions. So we have to be fully ready with our knowledge. I would just like to remind you, beta, that whatever score you are going to get, this depends on what? This depends on few things. Your knowledge, that is the most important thing, for which you have really worked very, very hard for the last few months and also earlier. Number 2, your calmness. That means how less anxious you will be on the exam day. The positive approach, positive mindset. Right? These are going to be the few important things to give you a good score. We have to take stride everything, right? So first, if we focus on the knowledge, what we have to read and what we have not to read. Take risk in life, but calculate it. That means at this point of time, do not imbibe any new things inside you. This is the time when you have to focus only on the revision story, only on the revision story, right? So in the revision story, beta, this is just a glimpse of the various important topics in the various subjects. I'll be sharing a PDF of these most important topics in all the 19 subjects instead of reading out each and every topic right in front of you in this live session. Strategy, we know, is going to be important, but execution is everything. Incredibly successful people focus on executing incredibly well. जो भी हमने अभी तक पढ़ा है बेटा, ये जो आखिरी के 28 दिन हमें खेलना है, ये बहुत ध्यान से खेलना है. इसमें कोई भी हमें ऐसी एक्स्ट्रा चीज नहीं करनी जिसमें हम अपना कॉन्फिडेंस लूज करने वाले हैं, या कोई भी नई चीजें इधर उधर सोर्सेस से नहीं करनी है, क्योंकि हमें उन चीजों पे फोकस करना है जो हमारी ताकत है ऑलरेडी. उन चीजों को जितना ज्यादा से ज्यादा हम रिवाइज करें. I repeat this, that please do not add anything new at this point of time. Just focus on revising whatever you have learned in the last few months. That is going to be your execution. And execution is going to be your forte in these last 28 days. So please stick to your plans. Do not change your plans for something. These are just the important topics what we are going through, and some limits exist only in the mind. I just feel that there is nothing which can be limited. These are just the important topics in various subjects. In surgery, I would definitely like to give you a glimpse. General surgery, these are going to be the important topics. In trauma, the GCS, EDH, SDH, thoracic, abdominal, urethral trauma, arteriovascular, pediatric surgery, few important topics, adult surgery and onco surgery, which you can just go through at that point of time in the PDF. And now when you know what are the most important topics, this does not mean that you have to skip out the other topics. This is just that if you are facing some squeeziness in the time management, what you have to do is you have to divide your day into 3 to 4 sections. The wake up time, You have to maintain a proper schedule of waking up time. Then give time to yourself, maybe half an hour, 45 minutes or 1 hour, just to get freshen up. First 2 hours in the morning, you'll be focusing on the most repeatedly forgetting topics or the areas, and then splitting the day into two major sections, pre-lunch and the post-lunch. 5 hours, 5 hours. One subject, one subject. And then before going to bed in the night, you can just go ahead with the revision videos, the previous year questions or the MCQs, whatever you feel comfortable with. This is the study plan, which again I would be sharing you in the link of this YouTube video. The last 7 days, we have not divided the day into pre and post lunch session. Just try to wake up at 5:30 in the morning from 1st of June. Then freshen up, get ready by 6:30 in the morning, and then give time like this to these different subjects. The 3rd of June, you might have to travel to the exam city, some of you. So focus more on the images part and the PS surgery OBG PYQs on 3rd of June. Try to take a break between 12 p.m. to 1 p.m. and then 5 p.m. to 6 p.m. in the month of June, right? And try to go to bed by 10:30 from 1st of June. Rest of the days, you can go to bed at 12:30 in the evening, late evening. So beta, this is going to be the study plan for you. Just want to pump you up that just keep on believing in yourself beta. जो लोग खुद में विश्वास करते हैं, जो लोग दूसरों को नहीं देखते, जो लोग दूसरों को फॉलो नहीं करते, जो सिर्फ अपनी मेहनत पे विश्वास रखना जानते हैं, आँख खुले रखते हुए अपनी मेहनत पे विश्वास रखना जानते हैं, उनको हराना इतना आसान नहीं होता. I repeat this in English beta. If you keep believing in yourself, if you focus on yourself rather than focusing on others, that what he is doing, what he has revised, how many times he has revised, whatever it is, that is his forte. I know that 4th of June, this is what I have to do. And even if I am not able to complete even one single reading of the subjects, I still have got 28 days to go. And these 28 days are not small time. I can change the world in these 28 days. Who can stop me? I will do it. 28 days. जिंदगी के ये 28 दिन बहुत कीमती होने वाले. एक एक पल इन 28 दिन का, each and every moment what you're spending in these 28 days, have that positivity inside you, have that fire inside your belly, have that power to kill, that yes, I am going to read it. I know my study plan. I know what type of questions are going to be there. I know what are the most important areas from where the examiner is going to hang me around. But I am prepared. Even if I am not prepared today, but I will try my level best. I may not be the best, but at least I will try my level best to achieve the best. And believe me, my dear friends, you have the power inside. You have everything inside you to do it. And you will definitely come out with flying colors. Thank you very much. May God bless you, and just pray to God that may all your blessings be heard. May every one of you pass. Mist is always there with you. Thank you very much. God bless you.